How many of you were here yesterday? Most everybody? Okay. So I apologize in advance for a little bit of redundancy, but please forgive me. And then we may have, are these the updated? We updated some, okay. We'll figure it out. All right. So again, I'm Dr. Carson. I now run the Angelman Syndrome Clinic at Vanderbilt. By training, I'm an epileptologist, and but for our clinic, I've kind of taken over many roles. Again, we all, I think at this point, have disclosures. This was from the opening of the clinic, and I still love that shirt. So there's many abnormal movements in Angelman syndrome, and really the focus of today will be on the bottom two, so non-epileptic myoclonus and dystonia. And the focus there is that these are types of movements that evolve later in life in children with Angelman syndrome, so in teens and then adults. And at least for non-epileptic myoclonus, it's been very challenging to treat. And dystonia is something that we really haven't fully appreciated until recently. So again, the way I kind of think about problems is what is the problem? What is the issue? Why is it? And then, well, what do we do about it? And so I focused on the what and the what do we do about it a little more yesterday. Today I'll be a little more focused on why, and then hopefully, some of what we do about it. So again, I won't belabor this, but this is just to give some perspective on how we work to get some of the data that we talked about. And this all started in right around the peak of COVID. So we were trying to think of, well, what's a user-friendly way that we can get data, which means people can stay home. They can fill out surveys, they can make videos, they can send them to us. And I think people may question why I don't show data from all 47 patients. And part of that is because of the red box on this slide, is that there was a lot of overlap, and the challenge was what families called things maybe were different than what their physicians called things. And then when we actually looked at the data, that families were describing movements which had different names, but the descriptions were very similar. So it just proved challenging to say, well, what exactly are we talking about? So what we did then is utilize the videos that were submitted by families. And so for all of those that I will show here, again, families have consented to their use. So just starting with, and the two I'll focus on today again. So this is talking about a demonstration of dystonia. And the key thing is to, again, focus on the hands and the hand positioning, because some of these movements result from activation of flexor and extensor muscle groups simultaneously. And so the hands, or other body parts for that matter, can obtain these odd positions. And of course, these can vary to significant degrees. And so here's then a second example where it's more evident, well, we're in the hands, that's what you can see. So you can see that there's these abnormal movements in the hands that, depending on what he is doing, may or may not be disruptive to him. And he may have other issues, including, I have a different video that I'm not showing, that it was really a more severe myoclonus. So we also have, so my apologies. So, okay. I'm looking at different slides down there than what you're seeing here. So let's go back a step. And, all right. So, yeah, there is an updated one, but I think the updated one was... Okay. So, Okay. It's all right. Somebody should have been like, Carson, what are you talking about? Take a dramatic pause here. So, again, I go back. So, this video, probably very different than what I was describing before. This young lady, this is more of a tremor, and it's sinusoidal. And for her, it doesn't bother her. She was still able to eat. Mom was just very happy that we'd been trying to get this information, and it happened to be at the Angelman walk where she was like, she's doing it, she's doing it. So mom was very excited. Moving in the right direction. Almost there. And I think one of the things that to me is important, especially, listening to Andres, is, and I'll talk more about some of the mechanisms of these abnormal movements. And there's, one of the things that's very interesting to me is that some of the neurotransmitters that are involved. And so for one example, the medicine trihexyphenidyl is an antimuscarinic. So it limits the effects of the neurotransmitter acetylcholine. There's data from animal models about the role of the microbiome in the gut in metabolism of B12 and the effects that have on acetylcholine levels in the brain. And so it really just reinforces how there's these multiple mechanisms of things that play together. And, I would say a few years ago when people talked about the idea of the microbiome, I was like, okay, that's interesting. But the more time has gone on, it's just really intriguing. I'm glad others study it, but so again, this young lady has, and this is the challenge. What do we call this? She has myoclonus, and she clearly has dystonia. But when you put 10 neurologists in a room, is everyone going to agree? Well, no. A couple of people thought, there's maybe a tremor component too. So it just points out, it makes it challenging. As then when you imagine families are describing what they see at home, and we're trying to picture that in our heads, it makes it challenging. And here we go. So this is actually one of my kiddos who has more what's a myoclonus. And again, as we talked yesterday, differentiating this from an epileptic myoclonus. Now, you can't have myoclonic status where there's retained awareness, but she is aware, she's able to look at the camera, but it's very disabling. And we'll start her second one. And this is just a more severe example. And she's kind of an interesting case because when we think about all of the treatment options, so when I first met her, she was on a low dose of valproic acid. And I'm like, well, she's on a low dose, let's just get rid of that. And then over time, these worsened. And then I switched her to trihexyphenidyl, and mom was like, thought it was like the wonder drug. And including was like, hey, her stooling is the best it's ever been, which given that one of the big side effects I worry about is constipation, I thought this was really intriguing too. And so to me, this is important because a medicine like trihexyphenidyl is not a medicine that we would typically put high on our list of treatments for.
Acerca de estos movimientos mioclónicos degeneran en distonías. Entonces, para resumir un poco lo que hemos estado hablando, es tratar de identificar que estamos enfocados en lo que es la distonía. ¿Has notado en los videos que han subido que la hiponimia es una manera de describir lo que sucede en sus rastros? Esto tiene que ver también con los niños que son hiperactivos y son sonrientes, pero hay otros adultos que pueden perder este tipo de eh, típicos movimientos, lo cual es relacionado también a enfermedades relacionadas del Parkinson. Entonces, un par de adultos, de hecho esto fue en 2001, ellos describen que este evento se ve muy similar cuando las personas tienen un síndrome de Parkinson, lo que
is levodopa-carbidopa combination medicine that makes dopamine available. So there's a lot that we don't know about these movements. Why does it happen when it happens? Is there something changing? And is that something changing a functional change? Neurotransmitter metabolism, neurotransmitter clearance. There's evidence that the GABA transporter is a target of UBE3A. Well, is the dopamine transporter? And if it is, how would that manifest clinically? Is there a structural change? And now, could this be for medicines? Antipsychotic medicines affect dopamine. So there's lots of potential mechanisms. I've wondered about, again, nutritional deficiency, the interaction of B12, like I mentioned before, with acetylcholine. So there, again, a lot of unanswered questions. Now, it's complicated. So this striatum, there's all these lovely pathways they like to teach us that most of us then forget because there's direct pathways and indirect pathways, and there's multiple neurotransmitter systems. But when we think about the key ones that are relevant are ones that we all talk about. GABA, so the medicines we use to treat seizures, many act on GABA, clobazam, for example. There's cholinergic neurons, there's dopamine, and there's also serotonergic pathways that play into all of this. So now, the challenge with dystonia then is you can have dystonia from too much dopamine or not enough. And so it depends on exactly what is affected. Then we bring in cholinergic interneurons, which are neuromodulatory in the striatum. Again, they also do many other things. But I think the focus is that the idea is to some extent that dystonia results from too much muscarinic activation. Now, lots of data has come from the mouse models, which obviously, as we've all discussed, mouse are not humans, but we can only do so much in certain circumstances. But it points out that there's data that modulation of the striatum and the cerebellum, so two key structures involved in movements, behavioral consequences that correlate with the effect on dopaminergic neurons, decreased level, blah, blah, blah. Things go different directions, but increased serotonin and dopamine in the striatum. And then just pointing out, serotonin is the neurotransmitter we often associate with things like mood and anxiety. Well, there's also innervation of the striatum with serotonergic neurons. So to make it more complicated, depending on what pathways are involved, in the mouse model, some had increased dopamine, others had not enough dopamine. But reuptake, which is one of the things I've been curious about, was the same. Now, we also know that, so GTP hydroxylase is an enzyme that works as a cofactor that's required to make dopamine. And mutation, so loss of this gene, results in a different disorder called dopa-responsive dystonia. So it's a dystonia that's exquisitely responsive to L-dopa, adding extra dopamine. GTP hydroxylase is a target that's modified by UBE3A. So I think there's lots of different things that all kind of, bring in some biochemical rationale for a lot of these things. Now, I realize I think sometimes my brain works in probably not the best way, where I think sometimes I think sometimes I'm the anti-Allison, where things come in my mind and be like, well, this is why we can't do this. So, some of the, I would love to do dopamine scans. Dopamine scans, one, insurance doesn't like to pay for them. Two, you can't be on drugs that interfere with dopamine. So that means you have to stop many of our medicines for 2 weeks prior to the study, and you need anesthesia because you have to lay still during it. So many things that would be challenging to do with our adult kids with Angelman syndrome. Some of the neopterin and biopterin are markers for CGP hydroxylase. Those we would have to get from cerebral spinal fluid. There's special tubes you have to collect them in. Now with the ASOs, we're going to have a lot more access to CSF. So this is something that could be done. It's just not something I would be routinely likely to do in a clinic for the same reason that, it requires anesthesia to get the spinal fluid. And then some of the other tests that you can do to, for example, look at CGP hydroxylase wouldn't be relevant in Angelman syndrome because it's not affected everywhere. So what do we do about it? Just to kind of review, and a family made a good point on this, and I think it reflects some of the challenges we face. So this is from the data where we had video, and it's a small n. So this is people who had video submissions, so 9 patients who we said convincingly, this is myoclonus. And so from that group, here are the drugs that describe being used. And basically green is my good, that did something, where red is not so much. And Mom appropriately pointed out, well, you have clonazepam said it made somebody much worse, where it's one of the medicines that also made more people better. And that just points out the challenges that not everything works for everybody. And now, I can't tell you with the family that said the clonazepam didn't work, was it because they had side effects or it just didn't make a difference? But, it's, I think, what we know, and this is true for medicine in general, not everything works for everybody. Go ahead. I don't know where to point. It's not advancing. There we go. And again, I won't belabor this point. This is the same data for the group with dystonia. What I will point out is that the data I removed because none of this, again, small group, had reported using levodopa, carbidopa. Ropinirole is a dopamine agonist. Again, both medicines used to treat dystonias. And then modified Atkins diet or another medicine called tetrabenazine. So some of what too far ahead. Again, some of what I talked about yesterday is really focused on treating the triggers. And if anxiety is a trigger, we have treatments for anxiety. And so sometimes focus on the low-hanging fruit. It might be easier to find a medicine or another behavioral intervention that works well for sleep. And if that helps make the movements better, then focus on that. And again, we've talked about constipation a lot. And then, again, this is the magic bullet that I do not have. I wish I did. So we'll make him go away. But, the good news is there are a lot of medicines that work for some people. Again, not one for everybody. The main that we have the most suggestible data for are benzodiazepines. Keppra, again, valproic acid. There's a case report of perampanel in improving myoclonus in 4 patients with Angelman syndrome. Again, we talked a little already about cannabidiol, and there's a ton we need to learn there. I have a suspicion that cannabidiol can also, again, this is anecdotal from my own experience, I feel like in some children, it can help with anxiety. And so is it that things are better because they're less anxious? There's many movement disorder medicines which I think very well could be helpful. We just don't have the data yet to know. And that's what we have to keep working on, is figuring out, as we gain this collective experience, what works and, importantly, what doesn't. So, again, we talked a lot about epilepsy medicines, and I think the one thing I can say that's good about this is there's a lot of overlap between medicines between these groups. So a lot of the same medicines that treat epileptic myoclonus can be helpful for non-epileptic myoclonus, and then some of those same rescue medicines can be applied when needed. And we had a few things do funny things, so I don't know where they went. But what I was gonna, the last thing I was gonna point out was an example of another phenomenon that I've observed is Gelastic events in Angelman syndrome. So Gelastic is the fancy word for laugh-related. And so there's a variety of different types of laugh-related spells, and that can include Gelastic syncope, Gelastic syncope is one where people laugh so hard they pass out. There's Gelastic seizures, which the laugh is part of the seizure. And then there are things like cataplexy, which is a little different. It's a loss of tone, but in general, it's more associated with the, if I'm about to tell a punchline to a joke, before I get to the punchline, I may have a loss of tone, which is consistent with cataplexy. So I've collected some videos of children with Angelman syndrome where they laugh so hard, they pass out, and they have color change. And I suspect it's Gelastic syncope. Now, can I confirm that? Well, no, because some of those challenges, again, are, well, I need to have an EKG or an EEG on the head when it happens. I don't know when it's going to happen. Children and adults, if we bring them into the epilepsy monitoring unit, may not be so happy that they laugh really hard. We're kind of going on the clinical story. But what that got me thinking about, too, is that one thing I think is important to consider is that there, again, are case reports of specifically one where an adult woman was on a medicine that made her cardiac QT interval long. And she laughed so hard, it put her into an arrhythmia, and she died. Now, again, I don't want to be all scary and all, but the slide that was kind of cut off is a lot of the medicines that we use in neurology, especially some are really evident, like antipsychotic medicines, are known to increase risk for QT prolongation. So it's just something I think that's important to be aware of. Because all of this, I think, combines back to, I think the syncope is due in part to, again, my hypothesis is increased vagus nerve tone. There's case reports of children with Angelman syndrome who, with anesthesia, had excessive bradycardia that responded to atropine, which all would suggest increased vagus nerve tone. So it's just something that if we don't know about it, we don't ask the question. And if we don't ask the question, we don't know, is it that I just came upon 3 patients who do this, or there's more out there? And it suggests, and I've already done this with minimal data, just the simple point of saying, hey, you're about to have surgery. Just be aware, there's some reports that some children have had difficulty with their heart rate going too slow because of increased vagus nerve tone, and it's something that an anesthesiologist might want to know. So again, something very simple. It means they have an extra vial of atropine in the OR. So, all right. Thank you again for listening.
Bueno, estamos en la última.
Okay, so this is our last talk of the day. It's no less important. I know we're all very tired. Yesterday was a long day.